So our third speaker is Rhys Beynon. He's a dual-trained adult and paediatric emergency physician, but mainly does children now. He has seen that the need to specialise in these people who keep coming back to our emergency departments and to actually look at why that is and what we can do to help them. So thanks, Rhys.
Thanks very much. Perfect. So I've been asked to talk today about why does this team keep showing up. So I'm at St George's Hospital, so just to give you a brief summary of that. So it's in southwest London. It's a major trauma centre. We see about 33,000 children a year, so quite small compared to some of the Australian sites. And about 20 to 25% of those are young people. You can tweet me all you like. So I like to think of myself as an ally for young people. Now, we're going to talk about them as young people today. I'm joint trained, so some of you might have heard of these people as being described as the lost tribe, especially from the Royal College of Emergency Medicine. They don't quite fit in pediatric wards. You know, they don't like Disney walls and all the bubbles that we like to blow, and they don't quite fit in adult wards because they haven't developed their prefrontal cortex yet, and they're difficult to communicate with. So for me, a young person fits between 11 and 25, but for today, I'm going to talk about them from 11 up until their 18th birthday. And I'm lucky in our department, we will see in our children's emergency department children up to their 18th birthday. That's what I think is the right thing to do, and we can talk about that later. So I like to talk about them as young people, not adolescents and teenagers, because of what the definition of that is. So being young, so not me, because I'm now old, but this is where it gets important, is where we talk about them as persons or young people, because a person's definition means as a human being regarded as an individual. And that's what's important with this group, is that we need to look at them as individuals. I like to be an ally for them because essentially they're demonized in press. When you look at newspapers or the press and media, you see terms such as, it's all about knife crime stabbings, difficult behavior, risk-taking behavior, etc. And my favorite as well description of young people is that they're difficult. Rhys, can you come and see this difficult young person in 17? Or can you see this difficult patient who won't take his insulin and needs a little bit of time? And we sometimes use those words in the language that we use without even knowing, and that bias enters us subconsciously. And what we see around us enters us subconsciously. So even if we think that we're pro and we're passionate about young people, we've already still got that bias in that. I still have that bias in that, and I need to work every day to try and counteract that when I'm stressed and I'm challenged in my emergency department, that I don't face those biases. So top up on that, I'm talking about frequent attendances. So for those of you who work in adult departments in particular, you're a frequent attender who may, your alcoholic patient who's in bed one, who's attended 5 times today, who's got no fixed abode. Already, before you've even seen that person, your heart has sunk. How can you go into that person, into that cubicle and see them as that individual? So we've got a double whammy here. We've got the bias that comes with seeing a young person and the difficulties of that, and then a bias of being a frequent attender, and how can we counteract that? A lot of the feelings that I think that come with that is actual frustration, and this is what the underlying emotion is, but we may not know that it's frustrated. We're frustrated because we haven't got the time. We're frustrated because maybe we haven't been trained to deal with these patients. We're frustrated because there aren't any resources for them, and we're frustrated because we don't have the answer and it's not a quick fix. And as emergency physicians, what we like is a quick fix. You've got bronchiolitis, you're probably going to need to be admitted. We don't know what to treat for you. You might need some oxygen, you might need some feeding support, and you'll get better in about 5 days, and then you'll go home. But with these patients, we don't have that. So what I want you to do is we're going to take a moment, we're going to take it back in time for a minute. You're going to take it back to when you're an adolescent, okay? You're going to be 14 to 16 maybe, and I want you to think about what made you happy at that time. We're not going to be sharing it, so you're going to be keeping it to yourself. So some of the boys in the room have gone very quiet at the moment, but I'll share mine. So when I was 14, what I cared about was what Kylie's next album was going to be and whether I was going to be able to get it from Woolworths, whether I had enough money to do it, okay? So just take a minute, okay? Think about what made you happy when you were like a young person. You don't have to show it, don't worry. So it could be a place, a friend, a person, a holiday. I'm pretty sure that nobody in this room thought about attending an emergency department as being one of those favorite things, right? So these children who attend, or young people who attend emergency departments, something's gone wrong in their life, and that's why they're turning up. And let's try and remember that. And our job is to try and help them, try and find an answer for that. So obviously, like you're any good speaker in a conference, you have to change the title of your talk. So it's, why does this young person keep turning up? So what we do at St George's Hospital, so there's two ways that I look at frequent attenders, so to try and capture these individuals. So we have one stream. We have a safeguarding meeting that happens once a week, and one of our health visitors will look at essentially any child or young person that attends 3 or more times in a 6-month period. And our health visitor will review the notes. Now, sometimes that's quite reasonable because it might be a child with bronchiolitis or a broken limb or something, and they just, it's totally appropriate that they've attended 3 times. But if she's got any concerns, then we bring that case to the meeting, and then we'll discuss it in a multidisciplinary team format and see if there's anything else that needs to happen, and usually that comes to me. The other thing that I do is every quarter I look at my top 50 attendees that come to the emergency department, and that's from 0 up until their 18th birthday, and I look through them every quarter. So that's what I'm going to talk to you a little bit about now. So in the last year, these are my top 50s in age groups. So we've got a massive peak at the age of 1, 2, 3, which is where our peak attendances really are. So a lot of those will, though, be appropriate and will be bronchiolitis, viral wheezes, using an emergency department like a primary care service. And then we're going to look. It's happening everywhere, right? I'll continue. So I'm going to look at between the peak then. So you see then you get another little peak between 11 and 17. It's slightly higher. It's probably not that much significant, but it is. So we're going to talk at those. So we had 14 young people that presented frequently. And in my top 50, that was 7 or more attendances in a year. And it ranged from 7 to 14 attendances. So 14 in a year was our peak. So not surprisingly, 4 of these individuals had mental health problems. So that didn't come to a surprise to me. 2 of those patients were an inpatient in our local mental health hospital for the most of that year and kept presenting with self-harm to our emergency department. So even when you think you might have found the solution for them, you still may not have found that. To complicate it, one of these patients was 17 and was also pregnant. So that just added another layer to her attendances. This is the group that surprised me a little bit. We had 4 patients who presented with chronic pain. 3 of those had chronic abdominal pain and 1 had chronic headaches. Over the year's period now, 3 of those have now had a formal diagnosis of functional abdominal pain and functional migraines. And I'll talk a little bit about the challenges that they bring to the emergency department. Now I like to call these the all-sort patients. So they have a bit of everything. Usually these 4 top attenders, they all had one diagnosis that they were known in the hospital. So 1 was being investigated for a slightly raised creatinine, and the other 3, I think, or 2 had asthma and 1 had diabetes. So they knew the hospital, and they had confidence in the emergency department, and they liked to come back. So they used it as a primary care service. So for this, but it was probably appropriate because they had other stuff that was going on as well. So this is a group for me is where I like to think about trying to engage them individually back either to primary care or to our ambulatory service in pediatrics and trying to give them like an open door sort of access to try and reduce that number of attendances. One of our patients who's essentially one of my private patients, some of my colleagues are here. He's now 16. He's got autistic spectrum disorder. He's got very challenging behavior and problems. And he presents a lot to our emergency department and rather than attending his GP, because of his challenging behavior, he has to have 2 care workers with him at all times. And we've developed a rapport with him. He developed a hematoma in his pinna, and he needed multiple surgical drainages of this, and we actually decided that the ED was the best place for him to come through rather than going through day surgery because we knew him and we had a system for him. And it's about being flexible, and I think that's one role of nice being a consultant is that you can do what's right for the young person, even if you bend the rules a little bit. And we only had 1 young person in this group who had sickle cell disease. Now, some of you might have more. We've got a very small sickle population locally, but that's something for you to think about locally. What may not come to a surprise of you, 8 of the 14 were known to social care at some level. So that's just over half. Either had a named social worker, 1 was a looked after child, 1 was a child, some were child in needs, or some had some access to that. So that's just over half of these people who present frequently. This was a list that I wrote before I did the audit when I was told that I was going to do the talk about what other things I'm going to talk about. These are the things that I thought might come up in addition to the list that I had. So these might be relevant to your emergency department or your departments. And I think that's important for you to have just an awareness of what's happening locally, because what you need to do about it will depend on what's happening locally. So when I was speaking to my colleagues, I'm doing this talk, what should I talk about? Because I could talk for days, everyone who knows me. And so they essentially said, so yes, Rhys, what we want you to do is tell us how to stop these people, young people, from coming back, or what interventions you can suggest for us to do. So obviously, I don't have that answer, otherwise I'd be doing the keynote speaker for this talk of how to stop these people from coming back. But what I can do is give you some helpful tips of the things that I've learned over the few years I've been a consultant. So the frustrating thing is that you do need to give these young people time. It's not something that if you've got a busy department and you think, right, this is a quick fix and I'm going to sort it out in 7 minutes, you have to, once you've identified that this is somebody who presents frequently, you have to either identify somebody who's got time or you need to make time for yourself, because otherwise if you go in there without time, it's going to fail. And sometimes once you've identified that these are a young person who present frequently, this is your time to try and sort it out, and you sometimes just need to invest in that moment, however frustrating that is. If you don't invest then, you'll see them in 2 days' time. And then it'll be someone else's problem, maybe. What I like to do is observe. So I like to just watch what's going on, and this for me is really, really powerful. So I like to observe the interactions of the young person, what their behavior's like and how they're behaving and why they're behaving like that. What their interactions are like with their parents. So what's going on in that imbalance, and what their interactions are like with me as well, whether they're engaging or not. I also like to watch the interactions of the staff around the patient and to see what biases are in there, and listen to things that are being said. Oh, she's in again. You know she has only got functional abdominal pain. You know it's not real. She's just seeking morphine. Then I know, okay, right, there's some training that I need to do in my department, and there's individuals maybe that I need to focus on that. You need to listen. I know I don't need to tell you this, but I like to listen to the young person first and then the parent or the adult that's with them separately. It's simple. It's back to basic stuff. I ask them what their ideas are, what their concerns are, what their expectations are today. Then I ask the parent what their ideas are, what their concerns are, what their expectations are. There may be parallels, or there may be absolute discrepancies in the both. And for me, sort of listening to begin with is probably the key. And language, to try and get that language right from the beginning. Communication skills is key for this. You've got to practice speaking to young people to get it right. I'm passionate about this. I could talk to you about that separately. The way to get it right is to practice, to talk to other people, to do simulation, and to get it wrong sometimes, and to reflect on when you've got it wrong and change what you do if you do get it wrong. The important thing is that every time you see a young person or a patient, you should respect them with empathy, respect, and not judgmental. Then you have to then question those biases that are there, whether you know whether they think that they're there or not. You might think that they're not. I know that they're there with me, and I'm passionate about this subject. So I will still say for this patient who's challenging, I don't like to use the word difficult, is that, okay, Rhys, can you find some space to go in there with some empathy, respect, and be non-judgmental about this? And sometimes that means leaving the department and having a cup of tea and taking a deep breath, because if you don't look after yourself, then how can you look after these people? I'm sure most of you, you're all pediatricians in the room, you all have used HEADS. It's an amazing tool. I use it all the time. I tell everybody to use it. It's a tool to do a quick psychosocial history. It doesn't take long when you get used to doing. There'll be about 15 S's at the end, I'm sure, and some people put S. Social media flips into each. The other important thing is sleep. That's the reference for it if you want to take a picture. I can post that later. So what are the answers? Well, mental health problems, obviously the answer is to try and stop them from coming in crisis in the first place. I can't do that. And it's a problem everywhere, and we're seeing more of it. So the simple thing for me is to try and think of it in 3-stage approach. So I do a triple assessment, and I try and teach people to think of things separately. So we do a physical assessment. Then we separately do a mental state examination, and I try and encourage the junior doctors to do that, not just psychiatrists. And then a separate safeguarding assessment. Some people like to think that if you've got a mental health diagnosis, you've got a safeguarding concern, and those two things go in parallel. I disagree with that. They do sometimes cross over, but they're not always exclusively, and it's important that you try and identify, actually, rather than just referring everyone who's taken an overdose to social services, actually referring the ones that really need the help so they can work on the patients that need that. The other thing is working out what's local for you, so working out what help groups are, youth services are, to try and engage young people locally to try and prevent those crises, and that will depend on what services you've got and resources you've got locally. So the patients with chronic pain. So these are challenging. The important thing is that you need to tell the patients when they have those pains, it's real for them. It's real, okay? And so when we had one of our patients who's our most frequent attenders, some people in the room know who she is, staff started talking about that this isn't real, this is not, she's not in pain, she's, and started withholding analgesia, etc., which caused a real problem for the young person and the family and the relationship between us. So it's about validating the symptoms. It's about keeping maybe the individual and the parent, communicating with those separately. But from my point of view, is once you identify what somebody who's going to fit and you think is falling into this path, is to get them admitted, get a team of people who's going to take responsibility for them, get a care plan for them, and as an emergency physician, be involved in that, because quite often, sometimes what their expectations aren't realistic, and it's about how you, when they present to an ED, they need to understand what's going to happen and how they need to behave and how you need to communicate and how everyone needs to communicate, and then how the staff understand that this is real, etc. So it's not easy. We can talk about that for days as well. I always stop and think, have I missed something? So I always think when these patients present, have I missed a brain tumor? Have I missed an abdominal cancer? Did I do a thorough examination? So that's one other thing. I share the stories with my colleagues, nursing staff in particular. What do you think's going on? Have you picked up on anything? Anyone who's presented frequently, I always take them to our multidisciplinary safeguarding meeting. We know that there's usually a correlation that there may need to be additional support. More than half of the groups that we saw needed support. I engage with the GP. I call the GP to make sure that we're doing the same thing and that there's the same communication that's happening. I also try and maybe sometimes have meetings between emergency physicians and GPs, nursing, so that and the parents and family, so to try and see if there's a plan that we can build in the community to stop them using the emergency department when they should probably be using. And that's worked really well when I've gone into primary care and met the families there. I'm blessed that we have youth workers based in our department. Essentially, from my point of view, sometimes I'll have that gestalt of there's something not quite right, but they're not going to disclose to me, and the youth workers will pick that up. The reason for that is they're not health, they're not teachers, they're not police, they're not authority, so they develop a band of trust with youth workers, and they'll maybe share things with them. We have then systems in place that they then need to refer to social care if anything's highlighted. Wow, I've got a minute. I'm doing good, for those of you who know me. So that I haven't got the answers, but I'm going to give you 3 things of homework. So what I'd like you to do, if you're interested, is the first thing is that I'd like you to look at what are your frequent attendances. So what are the things that attend locally to you, because that's going to mean you need to then look at what resources are to help your population, because it's going to be different for all of us. The second thing I want you to question is, do you feel like you have the training or the capabilities to communicate effectively with young people, and what do you need to do to change that, to feel more confident in communicating with young people? And then the third thing is I want you to look at what multidisciplinary team services or networks that you have locally that you could engage with. So when you identify someone as a frequent attender, is how can you fit that into that process smoothly? 4, 5, 6, I'm done. Over. Thanks very much.
Thanks, Rhys. I'm sure you've generated a lot of questions.
Hiya, that was great. Thank you very much. I think we all can picture the patients you have in mind. And I find that I'm a paediatric reg in a DGH, and I find that the recurrent acute abdominal pain ones that go to the surgeons, and then the surgeons say not appendicitis, home, and then we all try and get in there to try and manage it. It's nice if you've got time to give them a bit of a longer chat and have some follow-up and things. But for those who are on that horribly busy shift when you just know that you're just going to have to go and get this child out, have you got any resources that you send to patients? Or, when you've put the idea about pain gates in their head and kind of introduced the idea of this not being typical pain, sometimes I think you need to give them the time to go away and read about it themselves. I was wondering if you've got any resources you use for that.
I don't, but there are probably resources around. I think with those is just letting them go back to the community is not the right answer, though. So you need a system. So you either need a general pediatrician who's got an interest in this. So one of our newest general pediatricians who's been employed has now developed, she's got 2 of these patients, she's now an expert. So it's about whether then you get them fed into that clinic.
We've got one, but she's inundated with patients.
Yeah.
And I think also it's probably a bit about the passion of the person who sees that patient, because you know when it's busy, it's easy to say it's not appendicitis, go home. Someone's got to be the one to address it. I just wondered if anyone else in the room's got resources or anything.
Yeah, you're one of our, this is Carrie, who's actually one of our Band 7 nurses, who has worked as a pain nurse.
Is it for parents and parents and young people?
When you have that initial conversation, sometimes you give them space to go and talk about information on them.
There's a really good, it's an Australian website, Pain Bites. So just Google Pain Bites, but the bites is with a Y. And it's got loads of videos about chronic pain and how it affects your life and how it affects mood and how you can kind of make your life fit around chronic pain and mindfulness and stuff like that.
My advice, if you are giving someone that information, is that then somebody needs, because where does that patient go then beyond that? So then for me, if you're sending them back to the community, I would actually call the GP and say, I've seen this young person, I think it's this, can you follow them up and provide the support that's needed? And that needs to be a phone call rather than a letter, I think.
Thank you. Another fascinating and stimulating talk. I use the HEADS assessment a lot. And I'm aware when I talk to sort of 4-year-olds or 5-year-olds, through my experience, I've gradually learnt who my favourite characters are in Peppa Pig and Paw Patrol. And, you know, I can talk to them about what Rubble's doing or what George is doing. When I do a HEADS assessment with a teenager, you know, I consider myself relatively young because I'm still in my 30s. I realise that I am ancient. And I find myself alienated by a lot of their references, particularly when they say they do certain drugs, and I've got no idea what they are. When they talk about social media, but particular social media that I don't use. And I find that when I ask them what that is, that starts alienating me from them. I wondered if you felt that we should have a certain degree of training on what is common, what is now, what is the zeitgeist for teenagers, so that we can more interact with them through the HEADS assessment.
I do. I think it's a little bit like, how did you learn about Peppa Pig? You learn it by working and communicating with these young people. So I'm not afraid to let them teach me about it. So when Snapchat was massive, though, I sat myself down and I was like, I really have no idea what Snapchat is and what it's all about. So I sat down and downloaded it. It's been created so that adults can't work it. It's like all, do you know, I was just like in this lost fall. But I persisted with it. I found a young person who's in our family who sat me through and taught me to do it. And I think, yes, I think there needs to be, you need to like have some element of it, but I also think that you're not there to be their friend, and you're there to be their ally, and you're there as a doctor, and they have a clear understanding of those sort of boundaries. So when they speak to their teachers, they know what that boundary and those rules mean. They don't know how to behave with a doctor because they've not been told. So a lot of it is actually just explaining to them, I'm a doctor and this is how you need to behave with me. And actually explaining. I quite like to do like at the beginning of the consultation, because we've all been there, haven't we, when we've taken the history of the abdo pain, and its lower abdo pain is radiating to the thigh. It's a young girl and the mum's there, and you're like, oh, now I need to ask the parent to leave, you know, because I'm going to go down the sexual history. And actually, I do all that at the beginning. So I say, I'm going to speak to you, I'm going to speak to your parents, I'm going to ask your parents to leave, and then I'm going to examine you, I'm going to bring your parents back. Then what we're going to do at the end is I'm going to tell you what I think is wrong, and we're going to work together about a plan of what's going to happen next. So getting them to be involved, you know, and actually it doesn't really matter if I know what Snapchat is or not. You just need to know that they're platforms for communication and that they communicate really well on them, better than we probably do.
Do you mind if I make a cheeky comment on that?
Yeah,
because I work with lots of young people, and that's one of the most common questions that get asked. So there's actually quite a lot of literature on this now, and it's mostly from the States, and they've done lots of different surveys in different settings, whether it's sexual health clinics, general pediatric clinics, adolescent clinics. And time again, when you look at what comes up, when you essentially ask young people, what are you wanting from a physician, what are you wanting from a doctor, time and time again, it's always non-judgmental, treats me with respect, and knows what they're on about, which is no different from me or you, actually, when we go and see a doctor, to be honest. So I think it's a really good question. It's one of the things, actually, that I think doctors worry about more than young people worry about, and because we're caring, we want to actually be able to do our job properly, and it's really good we want to communicate effectively. The reality is, all the literature and all anecdote will suggest that young people don't give a crap whether you're on Instagram or whether you like Peppa Pig or not. They just want to know that you can do your job properly and treat them right. So,
thanks. I'm just going to go over to Twitter before we run out of time.
I think just one question from Jen. How do you go about discussing the possibility of a functional disorder with young people in the ED?
It's very difficult. Because it's a diagnosis of exclusion, so you need to have investigated properly. So I tend not to bring that up in the ED. I don't think it's the right place to do it because you don't have the follow-up, and I haven't probably done all the investigations. And there's some clever things sometimes that I haven't thought about because I'm an emergency physician that I might not even know about that might be a problem. So I'd let a general pediatrician do that. Yeah, I wouldn't, because I don't think, because if it's a little bit like saying, I think something like that is such a big thing for them to make a diagnosis. It's a bit like saying, you make an HIV diagnosis. Oh, I think you might HIV. Okay, now you're in an emergency department, but you've got no way of following up that. I think that's a big thing for the family to deal with, and I think you'll cause more trouble. I think somebody else needs to do that who can follow them up.
Okay, well, we're going to bring this session to a close. Unfortunately, we've run out of time, but please put your hands together for our three presenters.